Okay, now we are, I think, good to start. Good evening, everyone who joined recently. So, welcome to the module number 2 of our whole course. And this module is ensuring your medication safety through, accurate weight and body surface area metrics. So, this is going to be very special. Okay. This you can consider as a very basic calculation that one should be aware of. Okay. So, this module I will consider extremely important and basic because this is something which can bridge the gap between basic pharmaceutical calculations and what is real world clinical dosing decisions, right? So this module can bridge that gap. And until now, many of you might have seen, the doses which is written simply as the tablets or, as milligrams. So, however, in clinical practice, especially in the hospitals, I can say these doses are rarely random or, fixed. They are always carefully adjusted according to the patient specific parameters, right? So it is not like I'm talking about hospitals, right? Admitted patients. When the patient is admitted into the particular ward for the treatment. So in that scenario, never the random or any type of fixed doses you will find, right? So they are always, carefully adjusted. The doses are always carefully adjusted according to patient specific parameters. And, two of the most important parameters are this, that is weight based, body weight based, and body surface area, BSA, that is body surface area, weight based and body surface area. So you need to understand the basic difference if you don't know, first of all. And second, you also should know where to use weight based calculation and where to calculate according to the body surface area. What is the importance this two topic is holding? Okay, this weight based dosing always expressed as the mg by kg, right? So whatever the kg the weight is having, according to that milligram is, being set. And this body surface area, that is that based dosing is expressed as the mg by meter square. Everything will be clear to you in the upcoming slides, so don't worry, I am just briefing about what is coming in the session in the introductory slide only, so that you can be more aware. And also it can give some clues to you that what is coming in the session further, right? So weight based dosing has different unit, guys, and body surface area has also different unit, right? Different thing they are telling us, different expression is there. So this dosing methods, both of these are used, I can say routinely. Okay, these two are the very routine. That's why I started the session with the word basic, right? So this calculation is very basic, very raw one. If the person is, healthcare professional, so he or she should know this basic calculation at first, right? So you need to understand the importance and all, and these two are, I can consider, routine. Okay, routinely these methods are being used to calculate the doses in pediatric, okay, in oncology, in antibiotic therapy, in the critical care, also I can say in transplant medicine as well. Okay, so as a future pharmacist and clinical pharmacist, I can say pharmacy professionals, right? You are expected, no, I'm not talking about normal pharmacy cannot do it, right? They are also expected to do the same thing. Okay, you must be aware of the dose calculation based on weight, based on weight and body surface area. So you are expected not only to calculate these doses accurately, I can say, but you are also expected to understand why behind it. Okay, why these methods are used and when they are appropriate. Now these two are the simple questions many, many people fail to answer, many students are failed to answer, because they know how to calculate weight base. There is no big rocket science in it, right? There is a simple formula to apply, and every information is with you. Height is with you, weight is with you, and you can simply multiply and divide by some digits which are prefixed, some prefixed formulas we are having. It is very easy to calculate. But what they don't know is the reason behind why in particular condition we choose weight based, and why in particular situation we choose BSA. That is very important, when they are appropriate, right? So my learning objective is very clear. By the end of this session, you should be confident enough to look at a prescription and understand, to understand the rationale. Rationale means why. Okay, so you need to understand the reason behind it. Okay, you need to understand the why behind the dose, the units, and also verify whether it is safe, appropriate, or patient specific or not. That is a later step, right? First of all, you need to see the prescription, and if you are seeing a therapeutic approach, you just need to understand the why behind it, why it is in this specific unit, why it is weight based calculation and not BSA, or vice versa, right? So you need to understand why. This is what my learning objective is. I don't want you to remember the formula, guys. It is automatically fit in our mind when we are doing a thorough practice routinely. But what our mind doesn't know, that is the reason behind choosing the appropriate technique to calculate the dose, right? So this is what the importance this topic is holding. I hope it is clear to you and making sense. Let's start with the learning objectives. So learning objectives are the reason behind make you more clear about the by the end of the session what you will be able to understand. So before starting any lecture, it is extremely important to clearly understand what you are expected to learn after this session, right? So these learning objectives will guide our discussion, whatever we are going to do today. Say this, by the end of this lecture you should be able to understand. Very first box you can just see, you need to understand, you should be able to understand the mg by kg dosing, that is weight based, right? So this means you should clearly know what this milligram per kilogram represents. Okay, what does this milligram per kilogram represent, how it is calculated, why it is commonly being used, and especially in the pediatric, why in pediatric mg by kg is being used, and what is high risk drugs in which we can calculate mg by kg dosing appropriately, right? That is our first learning objective. Second, by the end of this session today, you should be able to understand and calculate body surface area, that is BSA. For that we have one formula with us, that is Mosteller formula. I will let you know what it is and how to use it. The name is Mosteller, I will let you know. So you should be able to calculate body surface area step by step using, height and weight without relying blindly on the any type of calculators. Correct? That is our second learning objective. Third is you should be clearly be able to differentiate between the pediatric and adult dosing, guys. So today we are going to slightly have the overview about this topic, pediatric versus adult dosing. So you should understand why children are not treated as a small adults, why we cannot do it, and why dose calculations differ significantly between these two population. Okay, we'll see some PKPD mechanism of pediatric, what is the exact difference and how we can calculate it. And the last is you will be able to understand how to adjust doses in obese patient and underweight patient. That is also very very extremely important. So you should know the why, why total body weight cannot always be used, and when the concepts like ideal body weight, that is IBW, and also there is another concept of adjusted body weight, that is ADJBW. These two are also required in particular situations, right? So I will let you know what is ideal body weight and what is adjusted body weight. So these objectives are important, not only for your I will say for your understanding, but also for your clinical, whatever you are practicing in your daily life, for your internship, for your clinical rotations, and for the future hospital practice as well, right? So I hope now this makes you more curious about learning the session today. Please have note and pen with you. So today you are just noting it down in the notes, and from tomorrow onwards, like I will share one small PDF document with you after this session, probably by tomorrow morning, and you need to perform a 5 dose based calculation. And before discussing our third module, I hope you will be prepared the assignments, and I will also give you some links to upload your assignments. You need to do it just because of my confirmation that you are listening to me and you are understanding the the whole thing. So I will let, so that for that reason, please take note and pen with you. And one you need to write a formula today in your notebook, and you need to apply this at the end. Correct? I will send one PDF file in the WhatsApp group, and you need to perform 5 little dose calculation by your side according to weight base and this BSA. So you need to aware. Okay, you need to make yourself present in this particular session, though it is online. So I need to understand that yes, you are taking the whole thing. Okay, so no assessment will be there, nothing will be there. Just you need to upload your whatever file you are maintaining on a daily basis, so that I can be aware. Okay. Okay, so let's start. I hope this is making sense that what are the learning objectives. These four pillars we are going to see today. And by the end of this session, this is our expectation. Okay, so we'll end at 8:30, and by 8:30, you will have this understanding of these four pillars. Okay, let's start. See, why prescription dosing matters, first of all. So we'll start with why. My whole modules, my all modules will start with the very first question, why. I told you the story behind it, right? When I was student, I was wondering 99% of the time why I am being studied this, okay? What is the importance? When I can apply? So I will start with why, okay? So see this, precision dosing. When I say precision dosing, that means it is specific, okay? Patient specific. It is not one size fits all approach. Okay. Precision dosing is one of the most critical responsibilities we can consider in the healthcare, guys. Okay. Not all can do it. Not all can perform precision dosing, I can say. This is a skill. So the basic principle is very simple. The right drug at the right dose for the right patient at the right cost. So when everything is right, you can consider it is a rational use of the drug. Another word for this is quality use of the medicine. Okay, so see, practically it is not possible all the time to achieve this goal, guys. Okay, we cannot always go with right dose, right treatment, right duration to right patient at a right cost. Not possible. But our ultimate goal is this. Okay, our ultimate goal is to achieve this quality use of medicine. Did I start recording for you or no? Just a minute, I will check. Yes, I think it started. Okay, so sorry. So that is why what we were talking, yes, precision dosing, right? So every time it is not possible to go for this thing, but yes, our ultimate goal is to do this precision treatment, personalized treatment with precision dosing, right? So ultimate goal is everything is right. So if a dose is calculated, incorrectly, two major problem can occur here. Two major problem. Either overdose can be the problem or the underdose can be the problem. So overdose, of course, it leads to toxicity, organ damage, or even death sometime. And underdosing, you can assume, that leads to treatment failure. Maybe disease will progress, right? Disease progression will be there. And in some cases, overdosing can result in antimicrobial resistance as well. That is also a global threat in the healthcare stream, right? That is also a global burden for us, antimicrobial resistance. And when we talk about resistance, there is always this antibiotic misuse is the reason behind it. So for an example, I can give you example here to understand why precision dosing matters. For an example, I can say excessive doses of aminoglycosides. Excessive dose of aminoglycoside that can cause irreversible kidney damage. Correct. So that is how exactly precision dosing is matters. If you are going with the aminoglycosides, you need to do a dosing calculation. And subtherapeutic doses of these antibiotics can promote the resistance as well as, that treatment failure and all. So precision dosing ensures that your therapy is safe, that is minimizing adverse drug reaction, avoid toxicity. Your therapy is effective, that means it is achieving therapeutic drug levels. It is effective, it is, patient centered, that means it is tailored to individual, I can say, physiological differences. Right. So this is why the precision dosing matters to us. It is helping us to avoid toxicity. It is helping us to prevent some underdosing things. Underdosing means the resistance and the treatment failure and all things, right? And it is patient centered approach. Whenever we talk about precision, that means it is personalized. It means it is individualized, right? You can see here the small line which is written below the heading, that the clinical significance of accurately calculating your dose based on individual patient parameter. If one person is having a kidney renal issues, and if one patient is not having, both of them having the same issue, still the dose will be different, correct? That is what the individual patient parameters check, and that is what the patient centered therapy means. So as a pharmacist, you play a key role here, right? You play a key role in preventing medication errors, guys. Okay, and further, you are ensuring that dosing decisions are scientifically justified. So that is the meaning of precision dosing. Okay. And we are focusing towards this. So next slide is dose calculation methods. So let's just understand briefly. Although we are going to discuss in detail about waste based and BSA, but you need to understand what are the three primary methodologies we are using to determine patient medication volumes. So in clinical pharmacotherapy, there are three main approaches. Very first is the fixed dose. Now what is fixed dose? As the name itself has meaning, the same dose is given to all patient, one size fits all approach, which is nowadays it is not that useful to us when the resistance is evolving. That the disease progression is happening. We have multiple cases, which are coming in the coming in our uh, stream. So in that scenario, fixed dosing is never that useful. But the meaning of fixed dose, that regardless of any weight or size, you are giving or dispensing the medicine. For an example, paracetamol 500 mg tablets for the adults, that is fixed dose, right? So for an example, dolo 650, so that is also fixed dose. So that is fixed dosing, that is also one of the dose calculation methods. But there is no calculation required because it is a fixed, but still it is a one of the types. Okay. Second, we have weight based dosing, which is mg by kg, and in this we need a little calculation. So the dose is calculated according to the patient's own body weight. Weight based, that means patient's own body weight. Now this approach assumes what? That the drug distribution and clearance, that increases proportionally with the weight. Please understand the sentence. This weight based dosing is the approach that assumes further that the drug distribution and clearance, that will be increase the proportionally with patient's weight. So for that reason, the medicines distribution, the drugs distribution and clearance, according to that, we need to maintain a therapeutic level in the patient's body, and appropriately that is maintained through their weight calculation. And that is what weight based dosing is, mg by kg. And next we have BSA, that is body surface area dosing, which is generally comes under mg by M square. I will let you know what it is and how it is being calculated in the upcoming slide. But just understand that this dose is calculated based on the patient's body surface area. Okay, so this correlates better with what? Physiological parameters. Like in this BSA, we need to check cardiac output and renal function as well. Two most important thing while we are handling BSA type of dosing. Okay, so fixed dosing is simple, but it is, of course, it is not that appropriate when the situation is critical, right? And the patient is admitted. Weight based and BSA based dosing are more complex, I can consider, but it can provide greater accuracy, of course, right, and greater safety as well, especially in the patient, like special population like children, or maybe some cancer patients, right? So in this scenario too, this weight based and BSA dosing is very, very important. Guys, if you have any problem in between, please feel free to drop message in the WhatsApp group as well. Okay. So I will let you know. Okay, so I think someone has some question. I will give examples in everything. Don't worry. In our upcoming slides, we have multiple examples in every detail. Okay, and what is clearance? So we clearance means what? The body is processing your active metabolite, that is chemical moieties, drugs specifically, and then it is clear out. Okay, it is being clear out from your body. So based on the distribution and based on the clearance, we need to adjust the range of the therapeutic range to the particular drug into the body to get the effect, right? So according to that, we need to calculate according to weight, according to BSA, we are calculating. This is just the overview. Slide fifth, that is the next slide, that is where exactly weight based calculation will be starting. See, so let's start with the very first. What is this mg by kg dosing? Weight based, right? So the term, first of all, you need to understand the term mg by kg, that stands for milligrams of the drug per kilogram of body weight. Please understand. Milligram. I hope you remember the previous session, yesterday's session, milligram. Okay. So I introduce you towards the fourth thing, kg, g, mg, and mcg, where this term was there. Okay. So milligram of the drug per kilogram of the body weight. I am again repeating because I need a proper understanding for this formula. Okay. So we need what mg by kg stands for milligram of the drug per kilogram of body weight. Now, this method is directly links, guys, the drug dose to the patient's size, I can say. Okay. Whatever dose will be there, which is directly proportional to the patient's own size. Size means weight. Okay. See, this standard formula is being written here. So, understanding the fundamental formula for weight based medical calculation, that is this. See, it is in bold. You can see that. So, we have standard formula for it. Dose in mg will be equal to the body weight in kg into prescribed dose mg per kg. Now this formula ensures that each patients receive a dose that is proportionate to their body mass. Okay, so we'll understand this by the example, so don't worry, we will understand by this example. So dose, what desired dose you can consider in the mg, that is equal to patient's own body weight into prescribed dose. Okay, mg by kg. So whatever patients has the weight in kg, right? So in that scenario, in that way, we need to calculate the milligram of the particular drug. So this is ensuring that each patient receive a dose that is proportionate to the body mass, that is reducing the risk of toxicity and underdosing, both of the things simultaneously. Okay, so this method particularly important for pediatric dosing, guys. Weight based calculation is very important for pediatric patient. uh, Also, I can say the drugs which are having narrow therapeutic index. I already explained you in yesterday's session what is narrow therapeutic index. Okay, so we need to maintain a minimum effective concentration and maximum safe concentration. The range between these two, that is therapeutic range, right? Therapeutic index. And drugs that has narrow index, very less difference in minimum effective and maximum safe. We need to do a lot of things to, maintain the appropriate therapeutic dose for the particularly those drugs, phenytoin, warfarin, and all, right? So for that also, mg by kg is very important. And for the drugs where body size significantly affect the distribution, for that also this mg by kg is very important. So understanding this concept is, I can consider fundamental. Okay, it is very basic. Before moving on to the more advanced dosing strategies, first and foremost is to understand mg by kg dosing. I will let you know lots of examples in upcoming slides how to calculate and how to assume. So in some scenarios we need to assume also, in some scenarios we need to precisely calculate. Practically, I am saying, okay, every time you cannot have pen and paper to do the calculation, but yes, I have some example to show you. That is what the mg per kg means. Now let's understand the importance first, what is mg by kg dosing is having. So see, this is playing a crucial role while, I can say, ensuring individualized therapy. When you are focusing towards individualized treatment, when the different weight patient has different weights, based on that you can calculate what is the exact amount of drug you need. So this accounts for variation in the body size, that further fixed dosing that is ignores. So fixed dose regimen ignores always this individuality, while mg per kg is, it is for that only. So importance, I think it is clear to you, because I already told you that this approach is specifically important in pediatrics, where the weight, weight is very different significantly with the age. Also with the antibiotic therapy, where achieving correct plasma concentration is critical in the neurotherapeutic index rate drugs. And in critical care, mg by kg plays an important role. So whether patients may have some altered pharmacokinetics because it is a critical care unit, of course they have some comorbid conditions and some other issues simultaneously. So in that scenario, the pharmacokinetics is altered. So in this scenarios, whether it is pediatric, whether it is antibiotic use, or whether it is critical care unit, this mg by kg dosing, that is very important. Clinicians always aim to achieve optimal drug exposure while minimizing adverse effect. So for that reason, this mg by kg is a very important things. I think these fonts are very small, but you can see this on the left side: individualized dosing and common in pediatrics and antibiotic use. That is what the mg per kg is holding. Now let's focus on the example to understand how exactly it is being calculated. So let's understand mg by kg dosing with a very common, which is pediatric example. So consider here a child. Okay, consider a child whose weight is 20 kg. Okay, have a note and pen with you. I already give you the instruction. Write it on it, mg by kg's example, and write that a child is having 20 kg of weight, okay, who is prescribed paracetamol. I am again repeating, who is prescribed paracetamol at 15 mg per kg dose. Okay, just understand these lines. For a pediatric patient requiring a paracetamol, the calculation is performed as follows. Step by step calculation is there. I hope you remember the formula. Identify the body weight. What is the body weight? 20 kg. Second step will be identify the prescribed dose. What is prescribed dose? 15 mg per kg. Now you need to multiply both. Okay, multiply both things. 15 into 20 you need to multiply. That is approximately 300 mg. Okay, so 300 mg will be 300 mg per dose, which will be required for the particular patient. I hope it is clear to you. Is it? May I know, or should I repeat? Is it clear to you? This is very simple, guys. Okay, this is very simple. If you understood the, okay, I will repeat once again. Someone wants it once again. So I hope you have seen this thing, this calculation. Please write mg per kg and write this formula. Required dose is equal to weight into dose in mg per kg, which is prescribed. Okay, the formula is very simple. Now imagine this child weighing 20 kg who is prescribed paracetamol at 15 mg per kg. Okay, so in prescription you will find it. Your responsibility as a pharmacist or a healthcare professional is to calculate the dose, what exactly being written by the clinician. We are not here to initiate the things. Okay, we are not here to initially write कि patient is required 15 mg per kg. That is not our duty. Our duty is to calculate the dose. So how we can do it? Step by step. We will identify the dose, sorry, we will identify the body weight first, that is 20 kg, and we will identify the prescribed dose, which is 15 mg per kg. So what happens next? If you required 15 mg per kilogram, so how much do you require for 20 kg? Correct. So you need to calculate 15 into 15 multiplied by 20. That is approximately 300 mg per dose. This represents a single standardized dose based on the specific weight of the child. If the patient is having 15 kg, you need to calculate by 15 by 15, or sorry, 15 multiplied by 15, right? If the child is having 10, of course, you will be calculating 10 multiplied by this 15, right? So as per this, you need to calculate. This calculation ensures that the child receives effective dose for fever or whether it is pain, whatever it is, and it will help him or her, of course, by recovery, and it is also leading to less toxicity. I hope it is clear to you. This formula is very important in case of pediatrics things. Okay, very simple. You need to identify the weight. You need to identify uh, the prescribed dose, 15 mg per kg. And if it is not available to you, it is also available in the guidelines, guys. Okay, so appropriately, pediatric is also having this range. So it is very easy to find out this prescribed dose. You need to just multiply, and that is mg per kg dose. 300 mg per dose. That is the range of paracetamol for a 20-year-old child. Is it clear? Is it clear? Okay, thank you so much for your reactions. I hope you are listening to me and it is not boring. Okay, so have the notepad with you, guys. Please mention all the things and try to, because it is very easy to remember now. It is very difficult to practice later. So please have notepad with you. Okay, so I hope it is clear to you. This is the pediatric example. Now let's come to the adult example for mg per kg. So although this mg by kg dosing is more common in the pediatric, I can say, but it is also frequently being used in the adults for certain drugs, certain drug classes, I can say. For an example, say this. Yes. So an adult patient here weighing 60 kg. Patient's weight is 60 kg. You can just write in your notebook that the adult example, patient weight is 60 kg, was prescribed amoxicillin. I am again repeating, adult was prescribed amoxicillin 25 mg per kg per day. Okay, 25 mg per kg per day. So what you will be doing here? 25 is mg per kg. Of course, for a 1 kilogram, 25 mg is required. For 60 kilogram, how much kg, how much milligram is required? So it is simple calculation, 25 multiplied by 60, right? And it will give you the dose that it is 1500 milligram per day will be ideal dose for amoxicillin for an adult. So this total daily dose is usually, divided further into multiple doses. We cannot give 1500 mg on a, very first in one dose only. Okay, it is divided further into multiple dose, such as you can divide three doses of 500 mg each. Okay, depending on the dosing schedule. So you can divide it further, but yes, per day you can have 1500. And it is also written, okay, it is also written that amoxicillin 25 mg per kg per day, which is required for an adult if you have if you want a therapeutic effect. So you just need to calculate it by the weight, right? So 25 mg is required for 1 kilogram, right? How much mg is required for 60 kilograms? So you just need to do a simple math here. Is it clear? Adult one. Both of this has the same things, right? Both of the things has same manner, but for pediatric is being it is being widely used. For adults, of course, I can say I already inform you that sometime, it is assumption as well in the practice. So yes, you can assume also in some situation. You will find in prescription the assumption as well. That is completely normal, because every time we cannot make a dosing schedules. If the case is very strong and suggestive you some dosing optimization, of course we need to do for individual patient, but practically it is very difficult. Any specific guidelines to divide the calculated dose? Yes, there is a guideline. I will let you know. We have another topic of discussion with guidelines. So don't worry. Okay, just understand the math right now. Okay. So, yes. So this is adult one. I hope it is making sense to you. But there is also a limitation. Okay, certain critical limitation of using total weight. We are here using total body weight. Okay, so if the patient is on a weighing machine and whatever weight is showing, we are taking it. But that fails in specific clinical scenarios, and you must be aware of it. So this TBW, the term total body weight for all patient, that can be, misleading sometime, especially in the obese patient. What will happen next if the patient is obese, right? For that reason, I have included one another topic at the end to discuss about dosing calculation in the obese patient and the underweight patient. So in total body weight, that does not, differentiate between what is lean body mass the patient is having and what is adipose, that is fat, the patient is having. And many drugs, I can consider many hydrophilic drugs, I can say hydrophilic. I hope you have idea what is hydrophilic and lipophilic. Okay, so many drugs, particularly hydrophilic, that do not distribute further into this fat tissues. So if total body weight is being used in the obese patient, you can understand it can lead to excessive dosing and toxicity, right? Because the weight is excess, like 120 kg patient is there. Now you are calculating amoxicillin as per 25 mg per kg per day. What will be the range of amoxicillin? So can you consider this? No, of course, because the patient is obese. If the range is more than 3000 mg per day, how can you divide in dosing? You will be end up giving 5 dose of the tablet, 500, right? Which is not possible practically, right? So in obese patient and underweight patient, you also need to calculate these things, right? So body composition fails to account for difference between adipose tissue and the lean mass. And some hydrophilic drugs, I already told you that it do not distribute into the fat tissues. So in that scenario, overdosing risk can be there. So therefore, what happens? Alternative weight concepts are also there. And we have here the IBW, that is ideal body weight, and we have adjusted body weight. These two components are there. I will let you know how it is being used for the, improving the dosing accuracy for a specific patients. So in obese patient, total body weight can lead to toxic concentration of hydrophilic drugs. You need to remember for now this concept. Okay. In upcoming slides, you will understand what is ideal body weight and adjusted body weight, and you can connect the dots further. So, what is maximum dose concept? You need to understand this before moving forward with the BSA, which is a body surface area. You need to understand maximum dose concept. Now, this is one of the most important safety principles. Okay, one of the important safety principles in the pharmacy practice, that is maximum dose concept. Okay, so no matter what your weight based calculation shows, the maximum recommended dose that must never be exceed, that is there. And I already told you the example. If the patient is having 120 kg and you are calculating amoxicillin, considering the adult, right? And you are calculating as per 25 mg per kg per day, what you will end up, right? It will be 3000 or more than that probably. So you cannot exceed. For that, we have one concept, maximum dose concept. No matter what your calculation is suggesting you, the maximum recommended dose that must never be exceeded. Okay, for an example, paracetamol has a maximum adult dose is 4 grams per day. Gram I used, mg nahi. Okay, so it is not mg. 4 grams. I hope now you remember that kg, g, mg, and mcg sequence. Okay, so 4 grams per day is the maximum adult dose. You cannot cross it. So even if mg per kg calculation suggests you higher dose, pharmacist must intervene and recommend further dose adjustment according to patient's criteria. So this concept highlights what? Your role, your role as a final safety checkpoint. And this is one of the major errors which are identified in the prescription, guys. Based on the mg per kg calculations, prescribers are making mistakes, sadly. And we are here as a final safety checkpoint in the medication therapy to always check maximum dose concept. We cannot 100% rely on what our calculation is suggesting. We need to correlate it with the clinical picture always. Okay, we cannot blindly rely on the calculation. Whatever calculation, whatever formula it is a formula. It is a supportive tool. Okay, it cannot replace your critical thinking skills and judgment. Okay, so we have maximum dose concept. You need to aware of this concept, and for that also we have guidelines. As I earlier told you, we have paracetamol as a maximum adult dose of 4 grams per day. I will pin you in the WhatsApp group the link of the guidelines. You can directly download from it, save in your phone, and you can use it whenever you are going on a ward round or checking, with the prescriptions. So this is maximum dose concept. Okay. Next, we have the BSA, second learning objective. I hope mg per kg, first learning objective is clear to you. Now that we have already clearly understood, I can say, weight-based dosing, let us move to the next important concept, which is a body surface area and which is commonly abbreviated as a BSA. Now, this refers to the, I can say, total external surface area of the human body. I am again repeating, it is referred as total external area of the human body. Okay, total external surface area of the human body, which is always expressed in the square meters, guys. Meter square. Okay, small m and 2. Okay, so that is square meters. And this clinically BSA is, consider a better marker. I can say it is better marker than the body weight, which we understand, right? Understood. So it is better than the body weight, I can say. And BSA alone is effective because it correlates more closely with, cardiac output, how much blood the heart is pumping, and the renal, blood flow, what is the drug elimination rate we can expect, and what is the hepatic metabolic capacity if the person is having. So how much drug is being metabolized, everything will be calculated in the BSA. So it is not always a simple formula. We need to correlate lots of things while using this BSA. Okay, so it is a, medical professional use this BSA because it provides a better correlation with the drug clearance and the cardiac output, and the hepatic metabolic capacity as well, which is not written here, but for your understanding I'm saying. So this is especially, very vital for the medications where very small differences in the concentration can lead to significant clinical effects. You can assume what will be the drugs. Narrow therapeutic index. Right. So this is why for certain high risk drugs, especially with those with narrow margin between the therapeutic and the toxic doses, like for an example, if you are changing a little dose, either you won't get any effect, or you will end up with the toxicity. That drugs are considering as a narrow therapeutic indexed drugs. For that, BSA based dosing provides greater precision and safety as compared to mg by kg dosing. Okay, that is the importance of BSA, body surface area. You need to understand in which scenario we are going with the mg per kg, and in which scenario we can go for BSA. I think we have some questions. Just a minute, as we have drug profile labels from where we can also know the calculation as well. As we have drug profile labels, from there we can also know the calculation as, yes, we can. In some cases you will be having on a label directly. How we will we come to know about specific mg per kg for different drugs? I will let you know in which scenario you need to go with mg per kg, in which scenario you need to go with BSA. After learning these 2 points, it will be very clear. So I told you, right, directly that in pediatric, in some oncology patient, mg per kg is the solution. But if your drug has narrow therapeutic index range, right? If your drug is having in a very special scenario where a little amount of dose is changing either onto the overdose or underdose, in that scenario, BSA is more appropriate option. Also, let me tell you, so now you have in clear idea in your mind that BSA is more reliable. So in certain pediatric calculation also you can use BSA in critical scenarios where mg per kg is failing. Okay, so it is all interlinked, guys. It is not like particularly we have algorithm. Yes, these are the things where we will use mg per kg, and these are the things only for BSA. That is not nothing like that. Based on your practice, based on your having cases, based on what exactly the scenario is, you need to decide mg per kg will be good option or the BSA will be good option. Okay, so internally also you can switch based on your requirement. So this is the BSA outline. What does it mean? Now, let's understand this oncology demands BSA precision. I want you to reflect this thing before going towards the BSA, how to calculate. Why? I already told you we'll understand why and in what scenario, right? So because these two are the very big scenarios where the patient and, not patient, students are failing to answer in the interviews, in the vivas, and in the ward round participation as well. They know formula, they know how to calculate, but not knowing in which scenario what to use, right? So for that reason I have included this slide. Oncology demands BSA precision. You need to aware. So oncology is the best, and most important example you can study where this body surface area based dosing is a mandatory to perform. You need to do it after weight based. Okay. So once you are done with mg per kg, you need to do it a body surface area. Like chemotherapy drugs, imagine. Okay. Chemotherapy drugs that have, what we call a narrow therapeutic window, right? Narrow therapeutic index rate drugs. That means a slightly lower the dose, you will be having treatment failure completely. Slightly higher dose, you will be end up having toxicity, severe. It can result into death as well. Chemotherapeutic agent induced life-threatening condition, right? Because cancer drugs directly affect what? Rapidly dividing cells, and even small dosing error that can lead directly to bone marrow suppression and some severe infections and organ toxicity and whatnot. So in this scenario, BSA is very important. Correct? So BSA dosing helps to standardize what the systematic drug exposure, how much amount of drug exposure you need systematically while treating the cancer patient across the patients of different heights and weights, making again chemotherapy for a safe and more effective if you are handling BSA calculation. That is what the importance of BSA. Why cytotoxic chemotherapy regimens rely exclusively on BSA for safety? That is the commonest question asked by the recruiters while you are handling a clinical pharmacist post interviews, right? So you need to understand narrow therapeutic window range of the drugs, and you need to do a systematic exposure type of things. Okay, so BSA further ensures consistent drug concentration is being applied across the patient of having different heights and different weights. So this is what the meaning of BSA. Now let's come to the formula. We know the importance, we know why behind it. Now we are here with the formula, how to calculate it. We have for BSA very popular formula, that is the Mosteller. Okay, so several formulas exist for calculating BSA. Let me tell you. Okay, we have huge amount of very big amount of formulas for the calculating BSA. Different reference book are also suggesting different type of calculation of BSA, but this Mosteller formula is most widely used in the clinical practice. Okay, most widely. Now understand the formula. You can see the standard mathematical equation used to derive further a patient's body surface area. We have Mosteller here is the gold standard for easy calculation in the clinical settings. And you can see here the formula. You can write it in your notebook. BSA in meter squares, like square meter, is equal to, we have this height in centimeter and weight in kg. We have square root, we have, and we need to divide it 3600. Now this is a standard value. Okay, so square root we have height in centimeter, weight in kg, and divide by 3600. That is BSA in square meter calculation. Okay, now this is a simple calculation, but of course you need to do a lot of practice. Why this modular is preferred always? Why? So simple and easy to remember. This is very simple once you are doing a practice daily with the BSA calculation. As I earlier told you in the introduction of fundamental session, yesterday's session only, those calculation understanding theory will be only giving you impact when you are practicing it in your clinical setting. That is the only way to master the dose calculation, guys. I will not give you any false hope here that by listening to me continuously for 1.5 hours, you will be able to do those calculation. No, that is not the magic. Okay, it is not overnight process, right? You need to calculate it throughout, right? So write down this formula. This is very simple and easy to remember. That requires only two parameters, height and weight. And if you have, you all have the gadget, right? The mobile phone. So square root is very easy in the calculator to identify, guys. Just do height into weight, divide it 3600 and square root, press the calculator square root. You will be having BSA value. It gives values, very close to more, complex formulas. We have some complex formulas which are, precise as if we are comparing it with the Mosteller one, but it provides a very close range. That's the reason this is being widely used in a clinical practice. And this formula is being commonly used in the hospitals, oncology units, and in examination settings as well. So what is the process? You can see here the blue, green, orange, and yellow. So we need to measure the inputs. What we need? We need height in centimeter. We need weight in kg. Already mentioned in your patient file. Then what you need to do? You need to multiply your height by weight to get the base product. Okay, the base value. Then divide it by 3600. This is the standard constant 3600, and then a square root. Take a square root of the result for the final the square meter value in a BSA. Okay, so just a minute. I need to write here that this BSA will be in meter square. Okay, so superscript will be there. So I hope it is understandable. And this is how you need to calculate. Is it clear? BSA. I will let you know what is the other formulas. Don't worry. Yes, BSA dose calculation used for the chemotherapeutic agents, guys. Is it understandable? Okay, thank you so much for your reactions. Okay, so this is the modular formula for the BSA calculation. We now have example. Of course, we will see everything with example. Take your note and pen, calculate it. Okay, so also you can have that. Just a minute. I think someone has one problem. Why she is not being able to rejoin? Okay, so let's start with this simple example. Take your note and pen that now you understand the modular formula. Let's apply it step by step to a real patient. So this slide is again very important because most calculation error happens during this application of BSA. So I always inform my students that try to calculate it again and again because it is giving you a close values, right? So let's take this patient. We have height here that is 160 centimeters. See, height of, we have patients here. For a patient with height 160 cm, that is centimeter, and weight is 60 kg. So you can calculate BSA square root height into weight by 3600. Multiply your height and weight. You will be having 160 into kg. So you will be having here 9600, the value. Just a minute. I think someone has problem in rejoining. Okay. Okay. So are you doing it? Yes, height is 160, weight is 60. You need to multiply, okay, and divide by 3600. 160 into 60 is 9600. And if you are dividing it by 3600, which is a standard constant, you will be having 2.66. I am also doing it simultaneously for you. Okay, you will be having what? 2.66. Now, what will be the third step here? Take the square root of this. Square root of 2.66 will be 1.63 meters square. So if the patient's body surface area is 1.63 meters square. Now I want you to remember one thing very clearly, that BSA itself is not the dose, guys. Okay, body surface area you are calculating. Okay, it is itself, it is not the dose. BSA is just a platform on which the final dose will be built. Okay, so I will let you know how to do it. Just a minute. Uh, I think they have some network problem. Just a minute. Okay. So is it understandable by you or no? Are you doing it? Yes, 9600, 2.66, 1.63. You can see here Mosteral formula result in the BSA is 1.63 meter square, and this calculated value is them used as the base for the specific medication order. So I am telling you that BSA we are calculating, it is not specific dose, guys. Okay, BSA itself, it's not the dose. BSA it's just a platform on which the final dose will be built. So think of the BSA as the size of the patient's biological canvas. Okay. Think of this as an patient's biological canvas, and on which the drug exposure will be painted. Okay, so that is the example I can give you. And always double check, like height is mentioned in the centimeter, you need to double check this always. Weight should be mentioned in kg, that what our formula is suggesting. Okay, and calculator is in the square root mode, you should use always. You need to do this thing, verification again. Okay, if you are not finding a mapped value. So, what happens? Let me ask you, what happens if the height is entered in a meter instead of centimeter, guys? What happens next? Dangerously wrong dose. Okay, dangerously wrong dose will be there. So you need to identify the height is in centimeter and the weight is in calculator. Okay, sorry, the weight is in kg. Okay, and the calculator is in square root mode. So that three thing you need to identify whenever you are calculating the BSA. Now let me give you BSA dose example. I hope how to calculate BSA is clear to you. We need to multiply height into height and weight. We need to divide by the constant 3600. We need to do a square root of it, and we will be having what? BSA for a patient. Okay, 1.63. Now let's come to the dose. Okay, now let's move one step ahead. How to do a dosing appropriately considering BSA. We already calculated. Okay, we already calculated the patient has BSA 1.63 meter square. Now suppose the doctor prescribes. Now imagine doctor prescribes 50 mg per meter square. Prescribed dose you will be having, okay, 50 mg per meter square of a drug. Very common in chemotherapy and immune suppression, guys, if you know. Chemotherapy agents and immune suppressions ऐसे ही लिखे जाते हैं. They are using this practice of mentioning chemotherapy dose and immune suppression dose like 50 mg per meter square. So what you will do now? What will be the formula becomes now? Total dose is equal to, please just mention in your notebook, total dose is equal to whatever order dose into BSA. Okay, and the calculated dose will be 50 mg per meter square was there written, and we have calculated BSA, that is 1.63, right? So 1.63 BSA meter square we identified, and the 50 mg that was written. Okay, for many chemotherapy and immune suppression, this is how they mention the drug. So the formula becomes the total dose will be the order dose into the BSA, whatever you find. 50 into 1.63, you will be having the range 81.5 mg. So the final dose to be administered based on body surface area is 81.5 mg. Okay, so because clinically this where precision matters most, you need to discuss and you need to practice this a lot. It is not that easy. Okay, but it is not that impossible, and we cannot do it. That is not the scenario. Okay, this is very simple. I started dose calculation by my in the second year itself, by whenever I used to go to the ward round and seeing the prescription, I try to solve it, because dose calculation always attracts me, right? If I don't know the dose calculation, how can I tell myself in a healthcare profession I don't know? So that sentence hit me, So for that reason, I dive deep into dose calculation every time whenever it is possible. So you can also do this practice. First, identify what is BSA, whether it is required for patient or no. Just if you have height and weight, consider, calculate BSA, body surface area. Once you have BSA with you, prescribe dose, multiply always. Then you will be having an appropriate dose. Then cross check is with the prescription. Sometime you will find it, sometime you won't find it. Okay, because assumption, based on therapeutic failure risk, doses will be large. These are also the scenario, but who cares? Just you need to do your thing first at your level. Just do it. Find out BSA once you have height and weight. Whether it is necessary or no, it is secondary thing. And whenever you are having this preferred dose, multiply by it, then you will be having your based on BSA calculated dose. Okay, so this is important, very important scenarios while handling immune suppressions and chemotherapeutic agent. Okay, and important discussion point I can say is does the formulation allow this 81.5 mg exactly? Might many of you might be wondering that if I want 81.5 mg, how can I prepare it? Do we need to, round up or, round down further, like 80 mg or 85 mg? Is there a maximum dose cap for this? These are the questions which are generally in comes in our mind when we are, doing a practice related to this. So in oncology, even, zero point 0.5 mg difference that can lead to toxicity, or it can reduce efficacy. We cannot do it. We need to do it on a that BSA preferred level. In immune suppressions, also same. We cannot round up or round down. In some cases, which is not serious, we can round down and round up. You will see in your daily practice that clinicians are doing roundup or a round down practice. Okay, so whatever close range formulation is available, they prefer that. But in oncology, in some serious cases, no, there is big no. Okay, so of course, in this case, would you round this up to a 80 mg or 82 mg? It is completely depend on the scenario, completely depend on what patient is having. Okay, what is the diagnosis, what is the situation? Okay, so always encourage this type of thinking. Okay, so this is very important things to discuss further. Now, let me discuss some drugs using, this BSA. So now you might be wondering that do we use BSA for every drug? Okay, so the answer is no. We are not using BSA for every drug. BSA based dosing is reserved for only high risk drug categories, guys. High risk drugs. So for an example, chemotherapy drugs, like chemotherapy drugs has very narrow therapeutic window. Small increase, severe toxicity; small decrease, treatment failure. So that's why an oncologist strictly follows what? This body surface area rule. Okay, and not body weight. And also we have immune suppressants. So that is using in the transplant patient. So overdose can if it there is a possibility of overdose, it will directly lead to infection and malignancy and death. And underdose agar ho raha hai, if there is a possibility of underdosing, it will lead to graft rejection in immune suppressions, right? So BSA is preferred when the drug clearance correlates better with the organ function, not just with the body weight. So that is extremely important point to remember. But for your practice, okay, on another hand, on your practice, simple prescription also you can calculate, okay, so that you can at least have that, like a muscle memory, these formulas will be fit into your mind, that I need to do a BSA calculation. I need to just do a multiplication of height and weight and divide by 3 thick 00 and square root. That is BSA. And preferred dose multiplication, that is the weight. Sorry, that is the appropriate dose as per BSA. So for that reason, for a simple prescription also you can do the practice. But remember, BSA is preferred for high risk drug calculation. Okay, so weight tells us the size guide, but BSA tells us the physiological exposure. Correct. So this is what the importance this BSA is having. Now we have a comparison like weight versus BSA approach. So I summarized for you. So this table, beautifully summarizes the strategic difference between mg per kg dosing and BSA dosing. So let's break it down the row by row. We have here the primary metric. Okay, so mg per kg, that is total body weight, and BSA is a surface area which is in the square meter square. Okay, so primary metrics is this two. Complexity, of course, mg per kg is simple. Okay, and one variable, while BSA is a moderate level we can consider. We need a two variable. Of course, we need what? The BSA first and then the preferred dose. Okay, and square root is also involved. So it is moderate we can consider. Typical use for antibiotics, some pediatric condition, mg per kg is being used. BSA is for oncology and high toxicity drugs, immune suppressions agents. Formulas, of course, simple multiplication we have for mg per kg, while in BSA we have Mosteller square root. Okay, so neither method is, better. Each is context dependent, guys. Okay, context dependent. If you mistakenly, use mg per kg for chemotherapy, what could happen? That is the simple question I can ask you. Okay, if you mistakenly use mg per kg for oncology drugs, chemotherapy drugs, what could happen next? What could happen next? May I know? May I know? What will happen next if you are using mg per kg in the chemotherapeutic agent? I will let you know, guys. I will let you know that if the weight is given in pound, how to calculate. Everything is coming. Don't worry. Two patients have same BSA but different body. I will let you know. Next topic is on that only, composition. Wrong dose, it can lead to toxicity. Overdose, toxicity, high risk. Yes, of course, it can lead to toxicity, overdose, and patient harm. We cannot do it. So you need to differentiate first of all, uh, in which scenario mg per kg is useful, in which case scenario BSA is useful. Okay. And also we have pediatric dosing differences, guys. So this slide carries a golden, sentence in the pharmacology, guys. So golden sentence kya hai? What is the golden sentence? Is the children are not small adults. Don't treat them like one. Okay. So this is not just a quote, guys. It is a clinical rule in our healthcare. Children are not small adults. Children are different from adults in metabolism, in organ maturity, in the body composition. So we never scale down adult doses blindly for the pediatric population. And that's why pediatric dosing relies heavily on mg per kg calculation, guys. Sometimes BSA in oncology pediatric is also useful in cases of oncology pediatric. It is another department. So if you give an adult dose, adjusted by age instead of weight, you can easily cause toxicity or therapeutic failure easily. Okay. So if you are, just adjusting dose by age, for an example, if the pediatric patient is having 15 years of age, so you are assuming that, okay, 30 years as an adult, I am taking 500 mg, so I can give a 250 mg half tablet to a 15-year-old child. This is ridiculous, right? This is not exactly the scenario. So of course you cannot go by age, you need to go by weight. You can easily cause toxicity in these scenarios, and this is why pediatric demands what? Accurate weight first of all, frequent recalculation also, and close monitoring as well. And one question was there from your side, body composition. So we'll discuss in this topic, how does body composition further affects. See this, pediatric physiology is very dynamic, guys. This slide explains why pediatric dosing is so sensitive. We need to understand water versus fat. Okay, neonates have high total body water, very low fat stores. Volume of distribution is another concept to understand. When the hydrophilic drugs like hydrophilic, okay, aminoglycosides, for an example, that can distribute more widely. Okay, but it require higher mg per kg doses with caution if you are using. Okay, so this children has dynamic physiology, organs are still in developing stage, body composition keeps changing, and dose today may not be correct next month. So in this scenario, of course, we need to do a lot of things and a lot of calculation, and that's why pediatric doses must be reviewed frequently and adjusted with the growth. Okay, so I hope you need to understand that why can this, some antibiotics like gentamicin, that dosing in neonates, that is very tricky, very tricky. Okay, you need to understand volume of distribution, clearance changes, and all, to understand whole calculation behind the pediatric thing. See this, neonatal renal and hepatic immaturity is also the parameter to consider while handling pediatric dose calculation thing. So this slide explains the clearance, guys, which is half of the story of dosing. It will tell you. So very first is kidney function. Kidney function is extremely low in case of neonates. Glomerular filtration is very immature. Drugs stay longer in the body because of clearance is less, right? So because this glomerular filtration is immature, so drugs can stay longer in the body, right? Enzyme activity is low. For an example, CYP450. So CYP450 develops very gradually over the age, right? So over the time. And this neonates has, and the child has very low enzymatic activity, right? And I hope you might be aware of this idea that yes, 90% of the drug are being metabolized by the CYP450 enzyme family. Okay, so of course, metabolism is slow and the drug interval is long. Drugs like gentamicin requires longer intervals due to slow clearance. Clearance is slow because of this kidney function, right? We need to have long intervals between the doses. We cannot compare it with the adults one. Okay, we need to give them the time to metabolize and to clear out the drug before second dose. Okay, so yes, gentamicin in neonates we need to calculate mg per kg. Longer intervals is required to prevent accumulation and toxicity. Okay. So in neonates, dose size and dose timings are equally very important. See this pediatric pharmacokinetic, you need to understand little bit about ADME. Okay, so let's pause and summarize this pediatric pharmacokinetics here, because dosing is not just numbers, guys, right? It is about how the body handles the drug, and how the body is handling the drug is a PK things, right? Pharmacokinetic things. We need to understand the difference between absorption, distribution, metabolism, and excretion. Excretion is not mentioned because you can understand clearance, right? So you need to understand that how body is handling the drug in the pediatric things. We remember this ADME principles in the pharmacokinetics. In pediatrics, all these four are different from adults. Absorption, for an example, I can say gastric pH is very higher in the infants, guys, and gastric emptying is very slow. Again, repeating, gastric pH is high, emptying is slow. So some drugs may be absorbed very slow and very unpredictably. Absorption related things. Distribution, obviously they have higher total body water and they have lower plasma proteins. High body water, low plasma proteins. So you will be having free drug concentration that can increase in the pediatric population, and we have high risk of toxicity related to distribution thing. Also, we have third, metabolism. So, for an example, liver. Let's take, if the metabolism is there, we need to take the liver. So, liver enzymes are immature in pediatric patients, and enzyme activity also increases gradually with the age. I already told you, CYP family. And excretion, of course, kidneys are not fully developed and drugs remains longer in the circulation. That is what the excretion is. This is very simple. So this is why pediatric dosing cannot be casual or copied, from the adults, I will say. So when you calculate a pediatric dose, you are, respecting a physiology, not just a following a formula. Okay. So that you need to keep in mind. See this, the dosing difference between the child versus adult. You need to understand this. This table compares the children and adults side by side. Okay, and you will be easily having idea that what is the total body water in the pediatric and adult. Okay, so neonates has 80% of the body water when adult had 60% of it. So hydrophilic drug distribute more in children. Okay, that is what the conclusion is. Body fat, children has very low fat stores while adult has high percentage. So lipophilic drugs, lipophilic, that behaves very differently in both of them. We have liver metabolism. In pediatric we have immature and developing stage, while in adult we have stable until the old age, right? So again, we that is very important for the 90% of the drugs. Renal clearance significantly reduced in pediatric. It is still immature. In adults, we can consider a peak function. Okay, so this is a comparison table that a child's body is changing every month, while an adult body is relatively stable, guys. Okay, and that's the reason behind pediatric doses are very dynamic and adult doses are relatively fixed. Okay, so now let's come. Now you have understood the whole concept behind the pediatric dosing. Let's come to the case. Take the pen and paper again. Say this, let's apply all this theory to a real patient pediatric case. Here, the drug is cefixime. Okay, the drug here, analyzing a real world pediatric antibiotic calculation for cefixime. Drug is cefixime. Dose is 8 mg per kg per day. I'm again repeating, cefixime administration 8 mg per kg per day. Okay, and child's weight is 18. Child is having weight of 18 kg. How you will do it? Mg by kg calculation. Okay, so you will do, if we need 8 mg per kg, okay, for 18 kg, how much mg will be required? So simple calculation, 8 multiply 18, okay, and we have 144 mg per day. So this is the total daily dose which may be given once daily or divided depending on the formulation available. And you can divide it, of course, they 90% of the time they are dividing the dose. Okay, they are not giving the whole dose at once, depending on the situation and the necessity. Why this work is because dose is tailored based on the weight. This is why it is more specific. Not 20, not with the 20, not with 25. They are specific with the 18 kg. So 144 mg per day is the suitable dose for the patient. Okay, so we are here avoiding underdosing that might lead to the treatment failure, and we are here avoiding overdosing as well that might lead to the toxicity. But let me ask you here one question: what happens if this child gains 3 kg in 6 months? And that is very simple scenario. Okay, it is very routine thing. So what happens if this child gains 3 kg in 6 months? Dose must be recalculated. Okay, so dose must be recalculated in this situation. Okay, recalculation is required. So for that reason we cannot rely on a month back prescription in case of child. Okay, we need to do it again and again, the recalculation. And adult dosing differences, let's shift our focus to adult dosing, which work very differently. So in adult, most of the drugs use, that is having a fixed dose. For an example, 500 mg, that is 500 mg or 1 gram once or twice daily. This is fixed. Why? Because adult physiology is relatively stable, predictable, and less variable than the pediatrics. But this does not mean that weight is irrelevant, guys. Okay, weight-based dosing is still needed in the adults. In which scenario? When the patient is extremely obese, when the patient is severely underweight, when the drug has a narrow therapeutic index. In this scenario, mg by kg will help you. So fixed dosing works for an average adults, but not with the extreme conditions like this. In which scenario, what to use, I think it is clear to you. So let's come to now our last objective, which is obese patient challenges. So obese patients are one of the most challenging population I can consider for the dose calculation, guys. Why? Because they have very, altered distribution and altered clearance. So obese patient may, there is always a distribution which is altered and clearance is being altered. For an example, I can say lipophilic drug accumulates in fat and hydrophilic drug remains in plasma. So you need to check the chemical moiety's nature, that whatever chemical moiety you are using in the obese patient, what is the nature of the drug, whether it is hydrophilic or lipophilic. So if the lipophilic drug is there, it can accumulate in fat. And of course, in obese patient, there is high amount of fat. And in hydrophilic drugs, it will remain in plasma because it is resistant towards the fat. And of course it has they have the clearance altered, that means renal clearance that may be increased or reduced, and liver metabolism also change in the obese patient. So using total body weight blindly, that can cause what? Overdose. I already give you the example with amoxicillin with 120 kg patient. It is giving what? Hydro overdose of hydrophilic drugs. It further causes n number of toxicities related to nephrotoxicity, I can say, and it can lead to some serious adverse drug reactions as well. So, can we treat a 110 kg patient same as a 70 kg patient? Of course, no. That is the difference between obese patient. Let's understand here two different things to calculate ideal body weight for the obese patient. Now, to manage obese patients safely, we introduce another term which is not total body weight, but it is ideal body weight. Okay, so ideal body weight estimates further what a person should weigh based on height, independent of excess fat. Okay, this in ideal body weight is independent of excess fat. You need to understand this. We have formula here for this. For an example, for male ideal body weight, we have calculation 50 plus 2.3, that height in inches you need to do 60. And for female ideal body weight 45.5 plus 2.3, height in inches you need to mention. I will let you know the examples, don't worry. But this is how you need to calculate ideal body weight for obese patient. You cannot rely on a total body weight, right? So this is not the patient's real weight, guys. It is a reference weight for dosing decisions. So ideal body weight is not patient's real weight. First of all, understand. It is a reference only for dosing decisions. And ideal body weight is especially useful when what? That you cannot use total body weight, that would overestimate your dose, and when the drugs are hydrophilic. I am again repeating, when the drugs are hydrophilic, in that scenario also this ideal body weight specifically being used. First, understand the pharmacokinetic challenges the obese patient is having, and then we will see how exactly it is being calculated. So these are pharmacokinetic challenges the obese patient is having. This slide explain the drug specific behavior in the obesity, guys. So I already explained you this. Lipophilic drugs that increase volume of distribution, drugs hides in the adipose tissues, risk of underdosing initially will be there and toxicity later. And hydrophilic drugs, on another hand, we will be having, do not distribute into fat type of things related to hydrophilic drug. And using this total body weight cause what? Overdosing related to hydrophilic agents. This is the pharmacokinetic challenges we are having to, to treat obese patient. And we have very good example. For an example, uh, aminoglycosides, that is hydrophilic agent. Okay, so if I want to use aminoglycoside in obese patient, I need to calculate ideal body weight first. If I want to use a vancomycin in obese patient, this is partially hydrophilic. Still, I want to calculate ideal body weight. So these drugs should not be, dosed based on total body weight, what we understood mg per kg in the obese patient, or based on the BS as well. We cannot go by this things, right? So how we can do it? We have another concept, ideal body weight as well as adjusted body weight. Now this is where adjusted body weight comes in, and that is a, uh, compromise weight. Okay, so adjusted body weight has a formula, you can see here on the right side. It is equal to ideal body weight plus zero point 0.4, which is constant, in bracket total body weight minus ideal body weight. This is little bit confusing, but once you will practice it, it is, very simple. So adjusted body weight it is equal to ideal body weight. Have your pen and paper and please write it. Uh, Plus zero point 0.4, which is constant, in bracket total body weight minus ideal body weight. Why this zero point 0.4? Let me tell you why this constant, because not all the excess weight is pharmacologically active, guys. Okay, so not all excess weight is pharmacologically active, but some distribution does occurs. So that is the reason. And this is mainly useful for the aminoglycosides like hydrophilic drugs and vancomycin, which is partially hydrophilic. So in many protocols, you will find this formula. And adjusted body weight prevents toxicity without sacrificing this, efficacy of the drug. I will let you know by the examples how to calculate, don't worry. But you need to understand that this adjusted value provides safer middle ground for calculating doses of specific drugs like aminoglycosides. Okay. So let me just give you the idea about selecting the right metric, weight metric, how to calculate. So this slide is extremely important for your, understanding perspective. So we have three weight here. We have total body weight. We have ideal body weight, we have adjusted body weight, and another we have lean body weight. We have ideally four, and major is this because total body weight you already understood. For the normal patient, you need to do a total body weight. For the lipophilic drug, we need to understand the ideal body weight, and for the hydrophilic also we need to do adjusted body weight, and for lean body weight also, the mass of the body that minus is the weight of the adipose tissue. That is one of the calculation for that. I will let you know each of this how to calculate, don't worry. But these three things are there to adjust the obese patient. Now, let's come to the case. Have note and pen with you. Let's finish this section with the full obese patient calculation, guys. Now, the total body weight is 110 kg. When the patient is on a weighing machine, it is showing 110 kg. Ideal body weight, when you are calculating based on the formula I show you before, that is very simple to calculate. It is based on the height of the patient. Okay, that is 65 kg. 65 kg. What will be your adjusted body weight here? So adjusted is equal to ideal body weight 65 plus zero point 0.4 is the constant, and we need to calculate in bracket ideal, sorry, total body weight minus ideal body weight, which is 110 minus 65. So this whole formulation, if you are doing it in your notebook, you will find adjusted body weight 83 kg. Now just correlate total body weight when the patient was standing on the weighing machine, it was 110 kg, and adjusted body weight is suggesting you 83 kg. So you will use for dosing which um weight for this obese patient? 83 kg. So whatever you will do further, mg by kg method, you will use 83 kg for this patient. Okay, so if we use total body weight here, you know now what will be the scenario where but that is a huge difference between 110 and 83. Nephrotoxicity, overdose, ADR, all the possibilities are there for over obese patient. So this is how you need to calculate adjusted body weight for the obese patient. But for adjusted body weight, you need to have what ideal body weight for you. Okay, and for that I have also mentioned the formula here. Okay, so you can calculate based on the ideal body weight, which requires height. And once you have ideal body weight, you can calculate adjusted body weight. Okay, so this is, I hope it is clear to you. Okay, now this is very simple. Once you have practice in your daily ward round and all, it will be very easy to calculate. Whenever the obese patient case you are handling, try to do this calculation. Okay, based on the formulas I have provided to you. Now you need to understand this SWOT analysis of the obese patient dosing. For the sake of understanding only, I have introduced this slide. So this slide is little important because it makes you think, strategically, not mathematically. So let's look at the obese patient dosing using a SWOT framework. This is very common questions by the recruiters. Okay, when you are handling interviews. SWOT. Now, this is strength, weakness, threats, and opportunities. Okay, so that is a SWOT. Availability of standardized, adjusted weight formulas. Okay, the strength is the very first strength of this is they have standardized, adjusted body weight formulas. It is having growing clinical awareness and support from therapeutic drug monitoring, TDM support is there. So this tool help us to uh, do the dose calculation more safely than before. But what is the weakness? Weakness is enzyme activity, which is very different widely between the patients. It is also having weakness of underdosing lipophilic drugs and high chance of calculation errors. That is also there as an weakness. We have opportunities like personalized kar sakte hai. We can do personalized pharmacokinetic modeling. We can go on a pharmacogenomics integration in it, and we can also do a automated dosing softwares. Okay, we can also, that is opportunities further. But threats also we have on another hand, that is severe nephrotoxicity, subtherapeutic efficacy, organ failure complication. These are some of the threats. Now, these are the analysis of obese patient dosing. So, whenever you are using a calculation, we have strength, we have weaknesses, we have opportunities, and we have threats also. So, obese dosing is improving, but mistakes still carry some serious consequences. You need to understand. Last topic of the discussion for today is underweight patient. Let's discuss the other extreme, that is underweight patients. So most people focus on the obesity only, but underweight patients are equally risky, guys, because of low body mass composition is low, small volume of distribution, and this is directly means that drugs remains more concentrated in the plasma, right? So of course we will be having higher chance of toxicity, especially with some CNS drugs, opioids, sedatives if you are using in underweight patient. So always use the lower end of the recommended dose range, guys. I'm again repeating. Always use lower range of the recommended dose for the underweight patient. Okay, so in underweighting patient, less is safer. That is the ultimate line you need to remember. Less is safer. For an example, sedative risk in the underweight patient. This slide highlights very practical ICU and ward scenarios, guys. So they have altered distribution and they have, exaggerated effects I can consider. So, for an example, very minimal fat and muscles underweight patient is having, and sedative acts more strongly in this patient. So, you will be having exaggerated effects if you are using benzodiazepines, opioids, CNS depressions, and all. So, even standard dose can cause, excessive sedation to them, some cases of respiratory depression, prolonged drowsiness. These are very common things in the underweight patient. So monitoring is necessity. Monitoring is critical. You need to monitor respiratory rate, oxygen saturation, CNS depression in the underweight patient. So start very low, go very slow, and monitor closely. That is the ultimate line for the underweight patient. Okay, we have one case to understand. So this slide brings everything together, like weight adjustment, drug choice, safety. So scenario is, see, morbidly obese patient is there. Drug is being used is a vancomycin, which is having a high risk of nephrotoxicity. So approach is very simple. Like, do not use total body weight blindly in this case because patient is obese. Calculate adjusted body weight, monitor the level using the therapeutic drug monitoring, TDM practice, right? And then vancomycin, you need to monitor the whole level of vancomycin in this type of cases. And if overdose is happening with this type of patient, you will be directly seeing some acute kidney injury or treatment interruption, some poor outcomes, right? These are the things which can you can assume in this thing. So just imagine this integrated case as whatever formulas and whatever context of theory we understood today. Okay, so precision dosing is the difference between, guys, cure and complication, I can say, last line. Okay, so you need to understand this in practice in very detail. We have some another table for you. So this table is a quick clinical decision guide for your reference only. If you have standard adult, you can go for actual body weight, but the primary risk will be there, ADR profile. If you have obese, go for adjusted body weight and ideal body weight because it primary risk is having nephrotoxicity for hydrophilic drug. For underweight, you can still choose actual body weight, but you will be having drug accumulation risk. For pediatric, you will be having mg per kg total weight for, and you will be having some immature clearance. So this is the special population comparison matrix for your understanding. Summary you can consider for the session today. Okay, and we have some actionable insights for the clinicians. So these are, practical rules you should carry into your daily practice. Always verify your weight type, whether it is total body weight, ideal body weight, adjusted body weight. Also, you need to do it age related interpretation. Pediatric drug level is not equal to adult drug levels. Consider physiological maturity, whatever principles I have shared today with you, and use this master for BSA, guys, especially in the oncology. Always avoid switching formulas, mid calculation. So correct weight plus correct formula, that is what the safe dose is. Okay. So you also need to understand some calculation pitfalls to so that you can avoid it in your practice. Okay. So these are some common real world mistakes people are doing. Using the wrong formulas like ideal body weight instead of adjusted one, total body weight when the drug requires ideal one. Okay. Ignoring maximum dose limits means even if mg per kg suggests higher doses, you are not doing it. Manufacturer limits also your restriction. That is must be respected, right? So remember that math may say yes to you, but safety may say no to you. And you need to consider what is the exact clinical scenarios you are having. And according to, you need to adjust. Okay. So I have some clinical tips for you. This slide is a pure clinical wisdom I can consider. So always recheck your weight, renal function, liver status. Why? Because patient condition changes rapidly. Old data that can be dangerous. So the golden rule we have that a dose calculated last month that may be unsafe today. You need to do it again. Okay. So that is a pro tip. And we have summary. So let's summarize the entire module. So yes, precision dosing saves lives, by mastering these concepts: mg per kg dosing, BSA calculation, obesity and underweight adjustment. So you can directly, reduce some medication errors, improves the overall outcome, protect your patients. And this is not the exam related content, guys. This is clinical responsibility a healthcare professional should have, right? It is not about exam whether I'm going to write in exam the formula or not. No, this is the primary responsibility you need to have. This is future trends in the precision dosing, guys. This is coming actually. Okay. So the future of dosing goes beyond weight and BSA, guys. We now integrating TDM into it. We now integrating pharmacogenomics into it. I will let you know in tomorrow's module what is pharmacogenomics and how it is influencing whole thing, which is very interesting. We'll start tomorrow's module with one small story which can connect this thing, and we will move forward. Okay, we have another things as well, integrated models. Okay, that combines all together pharmacokinetics, genetics, patient's data, and lot of things. So in dose calculation, all things matters. So final takeaway from of takeaway message, like this is your final takeaway slide, guys. You need to have a very important decision based on weight, BSA, physiology, and they are not just numbers, but they represents the real patients. So remember this line: calculate twice, dose once. Okay, so precision is not extra work, it is the foundation of patient centric care. You need to understand this line. So, this is the end of the module today. I hope it is making sense to you and useful to you. Right? You may forget sometimes, some formulas over the time, but never ever forget this, that your calculation always matters. Every number you write that represents a real patient, guys. So calculate always twice, okay? And believe in your skills and never rush in the safety. That is what I need to tell you. Just give me a minute. I will be back. If you have any questions, query till then, write in the chat box. We'll solve it. There is no attendance form, guys, but yes, this is a recorded session. So, yes, our team is doing a monitoring. Just give me 2 minutes. I will be back. Just 2 minutes for water. I will let you know the guidelines. I will pin the links as well in the WhatsApp group to follow. If the weight is adjusted in case of obese patient, won't that if affect the therapeutic index, making the drug treatment subtherapeutic? I didn't get your question actually. Can you elaborate a little bit more? I will let you know the guidelines, okay? And we have another whole module on it, so don't worry. You will be having recordings. I will let the team know, and they will send. They will send today only, okay? The recording will be there. I'm just texting them. Just a minute. Yes, they are sending today the recordings of both of the uh, sessions from yesterday, the foundation session, and the today's one. Okay, one more question is there. Okay, see, this formula is also one of the oldest and classic method to calculate BSA, what you are telling. But why it is important? Because it was derived from directly the body surface measurement. Like, and historically, it is being used in oncology and research, right? And it is more used in research, as per my knowledge. Yes. So consider scientifically accurate this formula as well. You can use it, but in more clinical practice, they are dependent on the modular one. So you can compare the complexity, because this Du Bois is very complex, okay, and modular is very simple. We need a calculator also in the, scientific calculator is must in the Du Bois, while basic calculator is good to go with the modular. That is also the difference. Okay, and the modular is very fast and error risk is low. That is also the difference between these two. That is the reason behind modular is very practical. I mentioned that many formulas we have to calculate, but simplest I have put in front of you. Okay. So this Du Bois is this there, but this modular is one of the formulas we use in a clinical practice. I hope it is clear to you. Many formulas we have actually. If the weight is adjusted in case of obese patients, so the actual weight is not considered. If the adjusted weight is taken for the drug calculation, will it not give less drug amount? No, no, because this is not possible because you can see the formulas. It includes the height. So it is again a patient specific. Patient will receive exactly the dose they need. Okay, not that is not the possibility. Okay, so if you guys have any more questions, you can directly put it into the WhatsApp group or in person also you can text. I'm just a message away, gentle reminder. So don't worry. Okay, so see you guys tomorrow with some more exciting topics. Tomorrow we have one another interesting topic to discuss. Also, I will be sending one small assignment in the group, so you need to complete it. Okay, thank you so much, guys, for joining today. Thank you. Good night. Thank you so much for your appreciations. Thank you.